Right, good afternoon, everyone. So welcome to this Health Overview and Scrutiny Committee. This is Wednesday, 18th of January. We're here in the Sparking Hoe Committee Room at County Hall, Benfield. We have our agenda as published. First off, I'm going to just mention to everyone that you can probably see in front of you a different microphone system if you haven't actually used this one since the previous version. This one hopefully works, which is an added bonus, but it does rely on only one person having a button pushed at any one time. So please be very, very conscious about turning it off when you stop speaking so that somebody else can actually speak as well. It's going to be, I think, probably a little bit more unforgiving than the previous system. So going to start with item 1, which is the minutes of the previous meeting held on the 2nd of November 2022. I propose that these minutes are taken as read, confirmed and signed. Is everyone happy with that? Good, thank you very much. Item 2, which is question time. We have received no questions from the public. So move on to, we have item 3 in that case, move on to questions asked by members under Standing Order 7.3 and 7.5. We do actually have one question which we received from Mr. King, who unfortunately has had to send his apologies to this meeting, but the question is regarding the hydrotherapy pool. He's provided a written question. We had submitted the question for answer, been forwarded to the University Hospitals NHS Trust and also the ICB for written answers which were sought for this meeting. However, to date, I have not received any information response and am therefore unable to answer the questions from Mr. King. I am aware that the NHS obviously is under great pressure and may have many other priorities. But hopefully the information will come through in the next few days and we'll be able to provide a written answer to his question, which will obviously circulate to the meeting and include on any future minutes, if that's okay for the meeting. And that will pass on obviously to Mr. King as well. So item 4, to advise of any other items which the chairman has decided to take as urgent elsewhere on the agenda. There are no urgent items. Item 5, declarations of interest. Do any members have any declarations of interest? Mr. Newson. Any other items? No, absolutely none. Thank you very much. So item 6, which declarations of party whips in accordance with overview and scrutiny procedure rule 16. I don't think there are any whip declarations to be made. Nope. So in which case we move on to item 7, presentation of petitions under Standing Order 35. There are no petitions. So finally, we get to actually move on to the meat of the meeting. So thank you very much for everyone patiently waiting for that. So we have item 8, which is the winter pressures across the Leicester, Leicestershire and Rutland health and care system. This is an item brought forward to us from the Integrated Care Board. We have with us John Melbourne, who's the Chief Operating Officer at UHL, and also Nilesh sorry, I'm absolutely appalling with surnames. Ghani, fantastic, thank you very much. He's the Chief Medical Officer at the ICB as well. So thank you very much. So what I'm going to suggest is that obviously you've put together some PowerPoint slides which have been circulated to everyone. We do normally take all papers as read. I suspect that probably a lot of the questions will probably be related to items maybe not necessarily covered by the slides, but obviously great to have that background information. If there is anything that anyone wants to add or elaborate on of the presentation that's been supplied, by all means, please do. Otherwise, we're more than happy to actually move on to a few comments from your side to outline where we are at the moment, and then maybe we can move on to questions and start sort of discussion on the overall discussion points, if that's okay. Okay, over to you.
Well, good. So firstly, thank you for having me along again. I'm John Melbourne, Chief Operating Officer at University Hospitals of Leicester. So I'll just give some headlines. I'll not talk through all of the slides. You were kind enough to invite me twice late last year to talk through our winter plans, and I think it's important to present an update on that today. Firstly, I want to acknowledge quite how busy it's been across health and social care over the past few months, and particularly the past few weeks. I'd also think it's important to say that everybody's seen the wider press, the wider national media around the challenges the NHS is facing. And I think putting that into context for Leicestershire is incredibly important today. So please do ask any questions that you would like of me and us after we do some summaries. So first of all, one of the main metrics and challenges for us has been ambulance handover times, and you'd have seen that in the press nationally as well. We know this has been a significant challenge for us here at Leicestershire for a long time now. Today I can present some significant progress. So since the 20th of December in particular, we've seen a huge improvement in our ambulance handover times. An example to that end is last week we lost around less than 25% of the hours we lost of the same week from the 12th of December. So we've seen significant improvement in our ambulance handover times. You can see that in the chart there, apart from 2 or 3 days between the Christmas and New Year period where we were under significant pressure and had to declare a critical incident at one stage due to the pressures we are facing on our system. We still have seen and continue to see a significant improvement in our ambulance handover times, and that has led to East Midlands Ambulance Service having a significantly improved response time into our community. So that is a positive story to start with there. What I should say, though, is alongside that, this has been some of the most challenged times in the NHS, and certainly I think what many colleagues would say at University Hospital Leicester and in the system, one of the most challenging winters thus far that we've ever experienced. And so what we've done to improve our ambulance handover response times, including helping a facility to take people off the ambulances at our front door, including getting better flow through our emergency department into the community, including opening additional beds and commissioning additional care home capacity outside of that as well. It's also come at the consequence of more pressures within our hospital and across our system as well. So it's really important that we acknowledge, despite some of the metrics improvement, our colleagues in our hospitals and across our services would recognise this as possibly the hardest times of their career, some of them. Linking to that, we have seen really significant pressures and acuity through our emergency department and our clinical decisions unit at the Glenfield down the road. We've particularly seen incredible challenges in our respiratory pathways over the last month. We are starting to see that improve in the last week or two as flu is hopefully showing signs of moving in the right direction. We've also seen really significant pressures on our paediatric pathways, particularly across December. Again, everybody be aware of the national press around strep, etc. Again, we've handled that. The teams have handled that incredibly well with support from across the system as well to ensure that we maintain urgent and emergency capacity and as much elective capacity as we can. Again, we have cancelled less elective activity than we have done in previous years this year, which is a real step forward for us given our long waits. But we also do have to admit there are, on occasion, we have had to cancel some of our elective procedures. Again, always clinically prioritised to make sure it's those that are less clinically urgent that get cancelled. We do still have plans going forward. It's important to say that we don't stop here. We're not accepting of the position, even though we have seen improvement on our pathways. So we are hoping to open additional capacity in the next month, both in UHL and in community services as well. We've got more to do to continue to expand some of our services, for example, streaming from the ED stack. And by that, that's me slipping into NHS vernacular, so forgive me. What that means is if you call an ambulance, you will be part of what they call the stack. And we have colleagues who work on that to make sure that we get those people to the place that they best need for their care. If it's an ambulance, if we can get them to urgent treatment centre or somewhere else for their care, they'll do them. Again, it's better for patients and means that it reduces the burden on some of our ambulance services. And finally, just to say, I think it really is important to say that we've had a huge amount of support from our local authority colleagues as well to try and step up additional Pathway 1 capacity, which is to support people into home, and indeed to help with additional care home capacity as well. So we absolutely recognise this as a system effort to get to the position we are. And we know we have already started planning for next winter. So while we're also having discussions how we get through every day, we're having discussions about next 12, 24 months as well, to make sure that next winter is better than this winter. Happy to go into any further detail. Anything to add?
Yeah, I think John summarised it really well. I'm Neil Sangani, the Chief Medical Officer for the LLR Integrated Care Board, so pleased to meet you all today. I think one of the things that's worked really well for us actually this year compared to other years is how well we've come together as partners across the organisation. So as you know, we're working as an integrated care system, and the relationship with adult social care, with local authorities, with our public health colleagues has really helped us manage risk across the system. The risk to our patients and to our workforce has been really high and challenged this year. And a lot of those solutions involve partner working rather than just one organisation doing that on their own. We wouldn't be able to do that without that relationship and that way of approaching things. Just to add on to some of the things that John said, we are literally about to launch 9,000 extra appointments over the next 3 months in acute respiratory infection hubs across primary care, predominantly to deal with children, but also adults who've got respiratory infections and other respiratory problems, because we've still got a lot of challenge with our respiratory cases across winter. Flu rates are coming down slightly, and as are COVID, but actually we're expecting to have further waves of other viral illness in the next few months, and that's a real challenge for us. You will know also that from October of last year, primary care started an enhanced access scheme, meaning that within every primary care network, so the collection of practices together, primary care is now open 8 in the morning till 8 in the evening, Monday to Friday, and also 9 to 5 on Saturday. So this is providing more access for our patients throughout the different primary care networks across the county. In addition to that, we have found ourselves in a positive position. It's a numbers game, but actually of having one of the highest numbers of appointments offered in primary care in the 42 integrated care systems in the UK. We know, however, that sheer numbers of appointments on their own don't tell the full story, and we know that it's a sort of challenging experience for patients to get through on the telephone sometimes to their practices. But in terms of absolute numbers and capacity, we are doing everything we can to increase numbers and capacity. But as John said, we're trying to make sure that we get patients to the right place at the right time, and we're not bouncing patients around the system, and we're getting them the right care that they need. We're also progressing some ambitious plans with virtual wards. This is a new area of working in the NHS, actually, to be able to manage patients using digital technology, but manage them virtually where they may have been admitted to hospital. It's early days for that, but actually we've got a whole series of different virtual wards looking at heart problems, lung problems, COVID, other illnesses and infections, to try and keep patients out of hospital where possible, or even avoid them going in the very first place. We are trying to also ensure that we still focus on our COVID and flu vaccination programme, even at this point in the winter, to reduce illness, death and morbidity from flu and COVID, which is still significant for us as a population overall.
Thank you very much. I mean, there are so many questions that I think are going to come out of this, so thank you very much for that introduction. You just touched on the vaccination, flu and COVID in particular. I've seen a national stat which is, actually the booster program, bivalent booster program in particular, I think was actually a lot more successful than a lot of people had suspected it would have been. And there was a national stat that I saw that actually the number of cases that it probably diverted away from hospital, along with the flu vaccination program, was actually incredibly significant. I mean, to the extent that probably without a successful vaccination program, we would have ended up probably with an absolute sort of tipping point as far as access is concerned. And obviously at the moment there has, particularly in Leicestershire, there has been quite a lot of discussion about views on vaccinations. But I think the demonstration of its success, I think, is without doubt, without sort of hesitation, has been an extremely positive thing for the health service, and it's good that you actually touched on that. Can I ask a quick question before we actually open up to everything else? You've talked about quite a few of the changes, and you mentioned about obviously you're already starting to plan for next year, and I guess there's a certain amount of what's happened this year that probably has been a bit of a catch up compared to the previous 2 years, in the sense that we have flu, we have COVID, but we also have backlog from the previous 2 years as well. Can I ask, of the changes that you've managed to make for this winter? I mean, obviously the bus and the tent is probably the most visual as far as the outside world is concerned, but of any other changes that you've made, what has singularly made probably the biggest improvement to some of the figures? Because certainly I guess seeing these in isolation, you touch on the ICBs from elsewhere, seeing these in isolation, it's quite difficult to really get a gauge, a picture of how we are doing locally compared to regionally and nationally. Obviously, we all read the newspapers, we all watch TV, we all have a very clear view of where the system may be nationally. This paper and what you've just described, whilst clearly there have been moments of shock, actually seem to be probably better, or the perception seems to be better from an audience member seeing some of these figures than maybe the expectation that you would get necessarily from watching TV or reading newspapers. So what are we doing locally that's actually made a huge difference for this winter? And what permanent changes do you think are going to be coming to make future winters more winterproof from the problems that we're facing?
Yeah, I think it's quite a hard one to pin it down, and I'm going to bring Rachel in a second to help support with that answer. I think for me, it's the range of interventions we've had. So no one single intervention in and of itself would have managed this challenge that we've had over the winter period, but it's bringing all those together. One of the things that we absolutely know, though, is we have a very complex urgent and emergency care system with lots of touch points for our patients. So they have primary care, general practice, they have the hospital emergency department, we have urgent treatment centres across the county. And actually what's really hard for our patients sometimes is to know where the right place to go is. Obviously, we try to use 111 to direct patients and get them to the right place. But what we have done a lot of is what we would call clinical navigation, which means using our clinical staff in various points across the system to ensure we're getting the patients to the right place. So as John described, we are managing an ambulance stack. So we have quite a few patients who may have called for an ambulance, but actually their care needs a better place in the community. So one of the things, just to illustrate this point, is the Unscheduled Care Coordination Hub, which is where we've brought together a multidisciplinary team of community services, mental health practitioners, our ambulance service, and our 111 DHU service together to look at those patients who are waiting for an ambulance with less urgency, to say, actually, can we manage them in the community in a different way? And that's a really, it's been lauded across the country. We have people visiting our Unscheduled Care Coordination Hub because of the way it's working. And what we recognise is that we're actually avoiding those patients even getting to hospital in the first place, being an attendee in the emergency department, trying to find them a bed on the ward, and then potentially struggling to get them out of hospital on the other side. So whatever we can do to consolidate that community offer for our patients, to keep them at home, if that's clinically appropriate, has been highly successful. But I think the other thing I'd like to just advise is that I mentioned that the risk has been very high, and to manage risk at this level across a system does involve all partners taking their share, if you like, of the risk and helping to balance that risk across the whole pathway. And by having a focus with local authority colleagues on discharge, our care home and adult social care colleagues, it's really important then that we can improve the flow through the system, reduce the risk at the very highest points. What I don't want to say, though, is that it's been easy, and we may have improved some of those numbers that we've talked about in terms of patients and ambulances, but service and experience to patients isn't always great still. Waiting times can be long in urgent treatment centres. They can be long in the bus, if you like, the pod that we have outside the emergency department, and it can still be difficult to get through to primary care at times. So we still have a lot to do. What we're also trying to do concurrently is ensure that we're focusing on that planned care. What we know is that our elective care, our planned care, so those outpatient appointments that our patients are waiting for, if patients don't get them in an adequate time, their condition can deteriorate and then they can end up as one of our emergency cases. So what we're trying to balance is a crisis response, if you like, to emergency care, with making sure that we're focusing on planned care, elective care, routine care, the management of chronic conditions, so our patients don't deteriorate. I don't know, Rachel, you want to add anything to that?
Hi, I'm Rachel Dewar. I'm the AD for Urgent and Emergency Care across the system. Thank you. I would wholeheartedly agree with everything that colleagues have said. I think our ability to share risk and spread risk where we haven't been able to reduce risk has been one of the key factors. I would absolutely support that. We have also introduced what we are calling a system control centre, and this was a national directive. So I think what that's helped us to do is have much more oversight and visual and a single point of contact, so that we can look across the whole system and support colleagues to talk to the system and to each other, so that we can in real time address some of those challenges as they are emerging. And I think that is something else that we will continue to grow and develop, but I think has given us some advantages in managing those times of most pressure. But I agree, I don't think we can pin this down to one particular intervention. I think it's how those interventions have worked together.
And just coming back to the final point that I made, which was about sort of changes, permanent changes that are going to come through. So I know it's been mentioned in joint ask about I think it's dermatology are being sort of stripped out to become a additional bed space. I mean, I don't know what the timescale is on some of those changes and whether that's going to be a permanent change to try and increase bed capacity, full stop.
Yeah, thank you. So we're very clear in all of our winter planning which interventions are to treat the symptoms of some of our challenges, be that cohorting at the front door, and which interventions are to treat the challenges themselves, be that some of our additional capacity, outreach into the community, etc. I would say the vast majority, don't quote me on this figure, but it's around 90% of our interventions that we're putting in place we see as part of our long-term strategy. And that is, in certain areas, about right-sizing our capacity, be that in the hospital, in the community or elsewhere. In certain areas, about improving our productivity, making sure we've got that absolutely spot on, and none of us can say we're absolutely spot on with that at the moment. And doing more in partnership as well, both within LLR and beyond. And I think those three things together, be it on the elective care hub or elsewhere, is I guess the core of our strategy for UEC. There is a fair point, and picking up on your vaccination point, we also will build equity of access into this throughout. We know we have differential access to many of our services across the piece, and we can't lose sight of that as well, because we've got to do more to equalise healthcare and outcomes across LLR as well. And finally, on the point of dermatology and more, I guess this is what we're trying to do, is build sustainable interventions. We know that our same-day emergency care at UHL works incredibly well. It gets people treated and out on the same day. And so expanding that is absolutely the right thing for our strategy. Equally, services like dermatology, moving them closer to our community into bespoke buildings that are unused and are frankly not the best use of taxpayer money at the minute, is a really positive step forward as well, in our opinion. And again, that's planned to happen next month, actually. So it is part of the longer term strategy to be part of reconfiguration as well, the dermatology moves. So what we're trying to do is make the right moves across all pieces that will get better access for people on elective care pathways like dermatology whilst improving UEC.
Okay, I'm going to open up for questions. Sorry, Mike, do you want to come in first?
Thanks, Chair. Just for members come in, I wondered if it was worthwhile sort of saying a little bit more. We haven't got time to go into the detail of all those things on slide 4, but I suppose there's phrases like standardise, equalise and share risk, which I'm tempted to sort of nod at and go, yes, that sounds wise, but I don't really know what it means. But I know enough to mean it's not that easy, because ultimately you're dealing with not just system and pathway style discussions, but you're dealing with the ingrained behaviour and learning of individual staff members, clinicians or otherwise. So there's a sort of a flavour. If I say, what does sharing the risk then mean? It might be useful for the committee just to kind of put more of a kind of human understanding on it, if you could.
Yeah, that's a really good point, Mike, actually. And some of this is, as you said, how we adapt a pathway or a particular service so that the risk might be shared across different departments or different organisations even. But there's also a human concept to this, and this is our clinical workforce, who sometimes are having to make decisions that may not always feel absolutely like they're delivering gold standard care, but what they're recognising is that for example, to get a patient discharged into a community bed more quickly, or back to their home a little bit more quickly than they might have liked, means that somebody else can come into that bed who might have greater needs. So there's the human element to this as well, in terms of what our clinical workforce are going to have to do. So there's individuals managing risk in a different way versus us changing a whole pathway to deliver care in a community setting, for example. There's also something about recognising that some of the ways that we've worked in the NHS are the tradition, it's the way we do things around here. And I go back to virtual wards, for example. So we know that a lot of patients actually can deteriorate and decondition if they're in a hospital bed, despite the fact they're getting good medical care and good nursing care. And actually, if we were to give them that same treatment, but in a virtual setting, so in their own home with a team around them, with monitoring in a digitalized way, we will help them keep their independence and help sort of them recover and rehabilitate from the condition that they've got. So, but that takes colleagues into a different place of how they manage risk with patients that they're seeing. They may feel that that's a substandard level of care, or that it's tolerating a level of risk that they're not used to. It also means, though, so for example, our community hospitals looking at the way they're taking on extra patients on their wards, just as the University Hospitals of Leicester, as an acute hospital, has been having to do that to manage capacity. It also looks at whether we can manage more patients in crisis in a community setting if we have the right care and the right teams around them. So there's lots of examples of this, and some of this is going to be a cultural change over time that I think the NHS is going through. We also need our patients to understand this as well. So, for example, if I take primary care, a lot of patients will say that they can't get an appointment with their GP, but actually we've changed the workforce in primary care really quite substantially. And that might be that you can probably see somebody far more quickly if you're willing to see a different type of healthcare professional. So we need to take our public with us on this journey, because some of this is going to look quite different to what they expect in terms of when you call an ambulance, when you're in hospital, what you see your GP for. And so we need to make sure we're communicating this really well, and people are seeing the benefits of this too.
Thank you very much. Okay, I'm going to open. I've got lots of questions. So I'm going to go to Mrs. Newton, then I'm going to go to Dr. Hills, Mr. Harrison, and then Mr. Charlesworth, if that's okay. So Mrs. Newton first.
Thank you very much, Chair. I mean, my question really was around what more can we do to militate against difficulties people are facing and actually accessing not just GPs, but hospitals. In a part, you've answered that. Can you elaborate a bit more on how you think GPs can open out a bit more so that patients feel comfortable nowadays going in to see them for appointments? Because I think there was a lot of shutting down at one point of the GPs who were mainly doing a lot of consultation via phones and not face-to-face. Is that changing now? Thank you.
Yeah, that's a good point, really, and you're absolutely right. In the height of the pandemic, we absolutely went to a remote way of working to actually reduce patients having to come in and putting them in a susceptible position. We have a sort of benchmark that we think at least two-thirds to 75% of our patients should be seen face-to-face in primary care. It's really hard to make that a sort of a rule, as it were, because it depends on the case. But actually, what we're showing in Leicestershire County overall is that the majority of our patients majority of our practice, I should say, are hitting that target. So over two-thirds, if not 70% of our patients can get a face-to-face appointment. What we also recognise, though, and going back to John's point about health inequalities, that for some of our patients who are perhaps working full-time or struggle to get in, they actually still value a telephone consultation or a video consultation. It's more accessible for them. So I think we have opened up, and I think we can be confident that we're doing that now. What we're trying to do is to make sure it's patient-led. So if a patient wants a telephone consultation, they can have one. If they want face-to-face, we would support that and encourage that.
Okay, thank you very much. I think it was Dr. Hills next.
Perfect, and thank you all for coming here today. If I could be greedy, I've got two questions to ask as well. The first question was more about workforce, because it's fantastic we've got all of these initiatives in place, but if we don't have the staff there to run the hospitals and the health centres, then we're not going to get anywhere, are we? It's obviously a very, very difficult time in the health service right now, in the winter in particular. And I'd imagine that this is probably the point at which a lot of staff would put their hands up and say, do you know what, that's it, I'm out. You know, it's too difficult for me now, when it's particularly busy. So my question was more on how is staff retention going? I know it's obviously a long-term aim of the trust to recruit adequate staff, and it's tricky. We've spoken about that in previous meetings. How is that going? And also, how is the use of locum agency work staff is going as well? My second question, a slightly smaller question. We mentioned this critical incident just before Christmas. And actually, one positive of the critical incident was I must have been informed of that about 8 times, because I saw it on Facebook in a community group. I think I saw it in the news. My mother messaged me it. So at least the messages are getting out there. You just mentioned about different ways of healthcare locally working, where you may not see your GP, but you might see a nurse, or you could go to a pharmacist to get a prescription of something. I'm thinking, is there a way that we could communicate better those sorts of messages?
So if I take the workforce one, so it's a really fundamental part of what we're trying to focus on in terms of our longer term strategy and planning. So there's a couple of points here. There's the first bit, which is managing that crisis over the winter and making sure that our workforce and our morale isn't so low that we don't have an exodus, just as you described, because actually we've had people in tears, we've had people absolutely thinking of leaving because it's been so challenged for them, and that's just being really honest about it. However, though, I think overall we have a very committed workforce who want to get through this challenge and can see light at the end of the tunnel. I've been through difficult winters before. This is probably an exceptional one, though. But also what we need to make sure that we're doing is, with the plans that we've got in place, inspiring hope so they can see a way forward and they can see that we have solutions, so that we're not going to have this situation year long, but also year on year. The retention is really important for us, as well as recruitment. We don't want to just lose our staff. So we're doing a lot with our people plan, which is what the integrated care system has in place, to make sure we're looking at staff wellbeing. We're thinking about career opportunities for our staff. We've got ways of working across organisations to make portfolios and roles more interesting, moving people out in the community or into the acute trust if that's what they would like to do. But I think also what's really important is to recognise that the workforce is changing. So as you said, and I'll go back to primary care because I think it's possibly where there's the biggest change. Nationally, we have funding for additional roles in primary care. This means that we have community pharmacists, community paramedics, mental health practitioners, a whole range of staff that 10 years ago we wouldn't have had funded in primary care. And this workforce is very expert in the area that it looks at. And sometimes you get a better deal with one of these members of the team than you would actually the GP, because they're far more expert at their particular area, whether it's physiotherapy or mental health. So one of the things that we need to be able to describe to our patients is the value in seeing that wider workforce compared to just seeing the GP. But in terms of agency staff are really important for us when we're dealing with a crisis situation, when we're dealing with industrial action, when we're dealing with a critical incident, and they're a really important part of our overall workforce. But we want to move to a position where we're not having to rely on agency staff, and we're clear about our substantive workforce plans.
Yes, thank you. I'd agree with all of that, and absolutely the point that part of us presenting an exciting vision for the future as a trust and a system is to have facilities that are top class, and to present a vision that we are doing more on elective and UEC point as well. So it is a little bit chicken and egg, one could argue, but actually what we've got to do is both. Picking up the critical incident point, you're absolutely right. So I believe that at the time, every other trust in the East Midlands was on a critical incident as well, because of the pressures we were facing across healthcare at that time. We're very clear, and I'm very clear, that when if we declare a critical incident, we want it to mean something. It needs to serve a purpose. If we're in critical incident for 12 months, that doesn't mean anything to our population. And so I believe that's the only critical incident we've declared in this year, due to the emergency pressures we were facing, because they were extreme and we needed a different level of action across the system. In terms of communication, though, so we have a lot of discussion around this. We have a broader communication campaign called Get in the Know, which we think is really starting to hit off across the system. But equally, we still want people to present to the right place for their care if they need it. And what we don't want to do is say, don't come to hospital, because it's not so, because actually we still want to treat people that don't need to be there. Fundamentally, our message remains the same: is only come to ED if you need to be an ED, only go to a UTC if you need to be there and not primary care, etc. So what we don't want to do is completely change our messaging for 2 or 3 days, because the messaging is the same: present to the right place for your care. That said, it's good to hear that you heard through various sources.
Thank you very much. Can I just follow on a question about the use of the emergency department and urgent care centre? Obviously, there's now an urgent care centre at the LRI, sort of tagged into where the restaurant is, and I was just wondering how effective that's been at diverting people away from ED, and have you actually been able to see the benefit as hoped for, or has it just been more people have turned up because actually there's now somewhere else for them to actually go to, in addition to actually sitting at accident emergency?
Thank you. So it's a really good question. So we're currently doing a lot of that analysis. It is really hard to demonstrate causality on it. What I would say, and forgive me for the correction, so we don't have an urgent treatment centre at the LRI. What we have is something called a minor injuries and minor illness unit that you can only access through presenting at our emergency department. So it is not a walk-in service like our other, well, they're not walk-in services, but it's not like our other urgent treatment centres. In an ideal world, would we have it? No, but we also recognise that there are always going to be some people that come to our emergency department for that unmet demand. But we are clear with people when they come that these are the other services you should be accessing. You'll be quicker, you'll be able to get an appointment, etc., etc. Frankly, without it, we'd have really struggled this winter. We haven't seen significant increases in our numbers of, let's call it lower acuity patients over the last 6 months, but it's one which we're carefully keeping an eye on and will be part of our strategy discussions over the next 3 to 6 months. We are also, again, thanks to system partners, we're able to stream now at times from our emergency department to the urgent treatment centres, which is incredibly popular with patients and means that, frankly, we're able to say to them sometimes you can either wait for 4 or 6 hours in ED or we can book you an appointment in 2 hours at ODB. And that is much more preferable for a lot of patients.
Okay, thank you very much. Mr. Harrison.
Thank you, Mr. Chairman. Could I start off with saying how really pleased I am that your report on your ambulance times is really good. I mean, it's probably got room to improve, but that's significant what you've done there. So I think it's a very appropriate that we acknowledge that, because I in the past have complained about the times and the problems linked to it, and here we have something that's really factual and sort of accurate, so we know there's things happening good. I say well done on that. With reference to your winter care plan, obviously this is a document which talks of October to December, so obviously that's all historical stuff, and I just was sort of taken back when I looked at it, because I thought, wow, you know, there's 18 headings here on that sheet, and I don't know how far you've got with it. Redesign the GP acute care pathway, implement 300 virtual beds, increase UHL capacity, increase handover space, implement fuel poverty plan, and it goes on. I won't read all the boxes because there's no point in it. But, you know, maximising and implement, I mean, it sounds as though, you know, very powerful and positive statements. How much of those 18 did you actually achieve? Because that's what I'd have really liked. Your first note really excited me, that first page. Wow, that is really something on ambulance. Now I've got a sheet that it doesn't tell me anything other than lots of headings, and it would have been really helpful for us to be able to say out of 18 you got 4 or 5. Okay, well, that was better than a 0. Where are you on this? It's just slogans really, and the same now, which is only 8 boxes this time for the January to March. And I think it would really help if we could have substance so we could understand. And if it's not a win-win, okay, we understand this is a moving feast and you're trying to integrate things that you've never done in the past or would never even been thought about 2 or 3 years ago, and here you are now moving things round in pace in a way that other people have said, wow, what are you on about? So you're there, but we really need some front story to see so we can balance it correctly, other than just be mesmerised with all of those action plans. Did they all actually happen? If so, well, that's amazing. If not, can you give a brief where you've hit targets really well and where you've got work to do? Thank you very much, Mr. Chairman.
Of course, thank you. So from the winter plan, October to December, all of the boxes that are in green are the ones where we have fully achieved those targets. So in terms of the implementation of the respiratory hubs, the implementation of the unscheduled care hub, the push model, the increase of 111 and 999, the increase of mental health support, etc., they are all fully achieved. The boxes that are in amber, of which there's 5, that's where we've partially achieved what we set out to do, but we are fairly close to. So the 100-day discharge challenge, for example, had a number of factors to it of areas of improvement. Some of those we've achieved, some of those we're still working on. So we haven't fully achieved all of those things. And similarly, in terms of the maximising opportunities and use of same-day emergency care, we have those services in place, but they're not necessarily fully utilised at this point in time. The only one that's red is the implement the 300 virtual ward beds, and that's because we have opened a number of virtual ward beds, but we're not at the 300 or close enough to class as a number as yet. So that work is ongoing. I would say we're probably 50% of the way there.
Well, on that, I think once again we've got to say well done. 12 out of 18 is very measurable and worth noting and congratulating you on that. Obviously, there's other elements that you're improving on, but obviously the key to all of this is maintaining. You know, once you've achieved it, then you've got to hold those lines and targets as your actual performance standards, and you know. But I think that is really, really good, and I'm delighted to hear that, and congratulate everybody and all the staff involved throughout the hospital groups. It's real progress that's meaningful, so I think that's terrific. We should acknowledge that. Well done. Thank you.
Thank you for that. And yes, there are areas we're seeing improvement, but we recognise there's a long way to go in a lot of our pathways and the length of wait for patients. Just for absolute clarity on the readback, so these interventions are a direct update on the interventions we presented in the October HOSC paper, which do have specific numbers against. I think that's a fair comment that we should have put the numbers against these, but if you want the readback against it, it's the October paper that these were directly tracked to.
Thank you very much. Okay, I think we've got Mr. Charlesworth next, unless Mr. Harrison, you want to come back on anything? Okay, Mr. Charlesworth in that case.
Thank you, Chair. Broadly the same question as Mr. Harrison, it was going to be. The targets in the green, you've said now that you've fully met all of them, so that's fine. This is very easy to read. That particular slide, very understandable. I mean, it's my first year on this committee, but I found that very easy to follow and easy to understand. Compared to the next slide, that goes into sort of NHS speak for me, and I don't pretend to follow all of that. So I'm not going to ask you to explain it all to me now. That wouldn't be fair. But bearing in mind, if you can sort of go back a step and assume we're all the person on the street, it would be helpful. I mean, the acronyms and some of it is a little. Just one personal gripe. You kept using the word cancel. Postponed is the better word, I would have thought. None of these procedures, I'm sure, are going to be cancelled and never happen.
You're right. I apologise for that use. You are right. I should have used postponed.
Thank you.
Consider me corrected. Thank you.
Okay, thank you very much. Can I ask, unless there are any other further questions, I just want to ask one quick question. Really in relation to obviously the sort of redesign of the CCG into the integrated care board, partnership, service, etc. And just really trying to understand, so far, have you seen benefits from the changes? And if so, what are those in relation to what we're seeing today?
Yeah, thank you. So as you know, we assumed statutory position on the 1st of July last year, so it's still early days in the whole scheme of things. But actually, I referenced it at the very beginning, actually, and I think it's actually more than just us as an organisation, as an integrated care board, but it's that wider integrated care partnership, and it's that integrated care system. So it's how we're working together. And I think the key bit about this is the integration, that none of these things that we are trying to describe here in terms of urgent emergency care just depend on how good your ambulance service is or your emergency department is. It depends on how the whole system is flowing, and that system is wider than health. It's about our social care colleagues, our local authority colleagues, but it's about our population and our patients as well. So I think the ways that we are working are really positive. I think we've got some really strong relationships. There's a long way to go, I think, to achieve this. And actually, just when we look at that sort of winter plan for that we've described as January to March, some of that is actually longer term as well. And when we talk about achievement, it's a sort of, it's not a binary thing. It's not a yes, we've achieved it, no, we've not. We're always working to continue to improve. There's a continuous improvement journey with all of this, and we've got bigger challenges. But I think it's a really positive place. I think we've got really good relationships. I think we've got a lot more to do. But I think there are some things that we certainly wouldn't have achieved and we'd have really struggled with this year, and we will struggle with going forward if we weren't working together across the system. So I think it's been really effective. We're still learning as an organisation. We're still making sure we've got that interaction right, our governance versus the governance that individual organisations hold themselves, making sure we understand the ways that different organisations work is really important as well. But I think it's a really good start within 6 months of coming into statutory form.
Okay, thank you very much. Are there any other further questions? In the paper, you make reference to strike industrial action and the effect that's had on the service. Obviously, there are still more probably expected over the next few weeks and more. You also talked about, obviously, the flu and COVID waves hopefully reducing slightly. The paper makes reference to January and February as being sort of the peak months. Do you still feel that that's true medically, or is that because of other factors such as the industrial action?
You never know at the minute, but our projections suggest that they would be the most challenged months for us, particularly with respiratory illness, etc. In terms of strikes, we've had two that impacted us: the East Midlands Ambulance Service strikes on, I think it was the 20th of December and the 11th of January. Was it the 21st? 21st, very sloppy. And we have no further strikes impacting us this month. Of course, there might be further strikes announced in February, and we will prepare and we'll make sure that we're ready for them. We've handled those two incredibly well, and we didn't hold ambulances throughout both of those days, so we're able to release them back onto the road immediately.
So you mentioned, was it the 21st of December was the strike day, and that's actually down as one of the lowest handover days?
Yes, both 21st of December and the 11th of January were incredibly low handover days for various reasons. Do you want to come in?
So just to be completely transparent, we did put in a large number of additional services to support that on that day. So we had some additional private ambulance crews supporting. We also had a high number of additional appointments outside of the emergency department, and we also had a significant number more staff in the emergency department. So there was a cost to that, but patient safety was the most important thing.
Okay, I mean, it's good to see that whatever you did obviously worked, because actually, yeah, I mean the figures are quite extraordinary, really. So yeah, are there any other further questions? Aren't. Look, thank you very much, the three of you, for answering our questions. It's clearly ongoing by the sounds of it. Hopefully, in some areas, maybe over the worst, but still plenty to do, and particularly by the sounds of it, plenty of things to do ready for next winter. As they always say, in the sort of another place when it comes to local plans, as soon as you finish one after 10 years, you start the next, literally the very next day. And I suspect probably winter planning is probably the same in the health service. You're halfway through it and you're still planning for next year's. So look, thank you very much for joining us. And I'm sure we'll be seeing you again to find out how the rest of the winter went. Okay, thank you. So we're now going to move on to a few shuffling of chairs. It's been very, very different when we're 100% virtual, because actually it was all instant. You just flick off switches. Now that everyone's back in chairs, it's a bit different.
There's just one change. Instead of Judith Spence, we've got Sam Barrow on the screen.
Ah, okay, brilliant. Okay, so we're now on to item 9, which is the public health medium-term financial strategy for 2023-24 all the way through to 26-27. Just been informed by Ewan that we've got Sam Barrett, who's joining us in from finance, but we also have obviously Mike Sandys, our Director of Public Health, and also Louise Richardson, who's our lead member. And very good to see you. I was going to say you're missing a name badge, so we need to make sure there's a name badge for you. So thank you very much for the three of you to join us. Can I ask first of all, Mrs. Richardson, whether you would like to make some sort of opening comments as the lead member about the paper?
Thank you, Mr. Chair. Yes, obviously public health, just as every other department in the council, has had to obviously look at their budget quite carefully. There's lots of challenges to everybody at the moment for a budget, but we're continually reviewing services to ensure that they're the best we can provide for our residents. A thing that is important to realise is that the majority of the budget for public health comes through in a grant form. That means that there's certain criteria to work towards. And the officers are very proactive in looking at how we can deliver the services, both in public health, but also across other departments where it follows the criteria. We have and will bring services in-house where appropriate and where we have the resources. But ultimately with public health, I think often the benefits are long-term. You can't see things necessarily in the short term, but the more we do in prevention will obviously have an impact as people age and hopefully keep people as mobile as possible for longer. And that has an impact on health costs too. Thank you.
Thank you very much for that. So we have the paper obviously distributed on the agenda pack. We, as usual, we're going to split it down into 4 sections and go through all of those for any comments or questions as we go through it. Now, I'm looking at you, Mike. Are you happy to, as we get to each section, if I pass back to you for you to outline sort of the key points that you want to flag in each of those sections, and then we'll go on to any questions that anyone has. So anything that you have question-wise, if you can actually leave it to the specific section that we come to, that will actually help us to make sure that we're all sort of on the same page, and we'll start from there. So I'm going to start off with the first section, which is paragraphs 5 to 12, service transformation and proposed revenue budget. That also includes Appendix A. Appendix A is on page 27, but otherwise paragraphs 5 to 12 are on pages 19 to 21. So over to you, Mike, to start off with.
Yeah, thank you, Chair. So so just to summarise the bits, obviously in terms of the purpose of the report, as per paragraph 1, it's to provide information on the new medium-term financial strategy, so years 23, 24, 26, 27, as it relates to public health, and ask the committee to consider any issues as part of the consultation on it, to escalate to the Scrutiny Commission and the Cabinet. As Mrs. Richardson said in her introductory remarks, it's always a little bit different for public health because we are funded by way of the public health grant, which does come with a number of terms and conditions around what we can spend it on, notably as public health activity, which should be related to the public health outcomes framework as well. You can see in paragraph 5, we were lucky to get a 2.8% increase in 22-23 compared to 21-22. After some years of either flat cash or actually a cash reduction, it was a welcome increase. But Adrian will be the first to say, in the light of inflationary pressures, but also some built-in pre-existing pay awards to NHS staff, and a lot of our budget is tied up in payments to the NHS because of who we commission our services from. In itself, that actually meant quite a lot of efficiency within the department to, if you like, consume our own smoke. So that's the key one on 5. Clearly, over the last couple of years, we have received extra money through the Contain Outbreak Management Fund, so COVID funding, to enable a bit of short-term service delivery. In terms of proposed revenue budget. Now, Sam always knows I struggle with this one, but this year I think I've got this one right. So paragraph 8, the important thing really is that bottom line figure in bold, the proposed provisional budget. That is the total of savings that we are trying to make within the public health budget, so that it can be then spent on allowable public health expenditure in other parts of the authority. So that's not including what I just sort of talked about in terms of the efficiency savings to make certain that we just spend the grant, nor does it include service health delivery, where the impact is as much on other departments as it is on public health. So local area coordination and our prevention target operating model, I'd say it's called spend by public health, but the benefit is to other departments. It's a straightforward cash reduction there, and you can see compared to previous years that we are looking to save a substantial bit of extra money, particularly in years 23, 24 and 24, 25. So to lastly on that section, I think just the net budget hasn't necessarily changed an awful lot, but again, it does give a overview in table 2 of where we spend our money, and as always, particularly in light of that sort of nigh on £3 million savings target, a lot of this is tied up in core services. So children's public health 0 to 19 is a third of our budget, £8.5 million. That's the cost of health visitors and school nurses, for instance. Sexual health, which is the next item on the agenda, equally 4 million as substance misuse. They are not cheap services to run, mainly because of the staff costs involved. But hopefully that gives an idea of where we spend our money, how we're financed, and what our financial challenges are for the forthcoming 4 years.
Okay, thank you very much. Right, can I invite any questions or comments specifically just on those items? I think, I mean, if it's, so is that on a later section? You've identified that as a line on a later section? Okay, well, if you can find out which bit, if you've got a power enough number, that will help. Any other comments? No, we have no comments. Okay, that's the third section in that case. So when that comes under that, I will ask you for a question. Mr. Harrison.
Thank you, Mr. Chairman. Yeah, it's not easy reading, and it must have been a lot harder for the team to be able to produce these figures and that document. And all I can say is that if you can congratulate somebody with a heavy heart, but I think so, because I know this isn't easy for anybody involved, and they are enormous impacts. Those numbers are significant. And, you know, we're asking for comments, Chairman. I think it's an acknowledgement of how difficult that must have been. So easy for us just to pick up a sheet of paper and read a number, but the implications and agonising of how you can juggle and how you can do that must be inconsiderable. So I'd just say thank you very much. Thank you.
Okay, thank you. Okay, so if we haven't got any further comments, in which case, Mike, can I ask you in that case to move on to the budget changes and adjustments and growth for members' benefit? This is paragraphs 13 to 17, which can be found on pages 21 to 22, and also Appendix B, which is page 29.
Yep, thank you again, Chair. So not an awful lot in this section. Again, I think the main part for me is paragraph 16, where, as I said before, because of the way we're funded, we always make certain we spend the budget, no more, no less. So in terms of growth bids, again, unlike other departments, and I understand, you know, growth pressures and things like special educational needs imposes a further strain on the council's finances. We don't. We have to cut our cloth accordingly before we even start. So we never really do have a growth bid put in. Can't say much more than that. And in terms of savings in paragraph 17, in the next section, we'll come on to the individual detail, which is probably the more interesting bit. But obviously, again, in paragraph 17 in the previous table, hopefully that sets out the sum total we are looking to save over the course of the MTFS above and beyond what we've done before.
Okay, thank you very much. So I think we're probably actually only talking about paragraphs 13 to 16, aren't we? Because 17 is actually the next section anyway. So, okay, any questions or comments on paragraphs 13 to 16? Mr. Charlesworth.
Pardon my ignorance, but no growth, but potential savings, especially in the year after next. Why, if it's a ring-fenced grant, that we're going to get, do we have to make the savings?
That's a very good point. He says it's difficult to answer that one. You could, well, no, to be fair, there is a range of things across the authority which other departments deliver and spend against, which are fit within the public health grant and will have an impact on the health and well-being of the population, which could range from active travel within environment and transport, school crossing patrols, bits and bobs. Early help within children might be a classic example. It is a judgment call over which provides best bang for buck in terms of the purposes of the public health grant. Is it for public health services, some of the stuff we do around the edges, or is it within other departments? So we always try and strike a balance between public health spent and public health delivered, and public health spent and delivered in other departments, if that makes sense. I wish I had money to pay for everything I wanted to deliver and pay for stuff within the authority, which otherwise might be cut because other departments have got their spending, their spending restrictions. Clearly, we're not in a position where that's doable. So essentially, we have a savings cut because we are trying to substitute and make the grant go as far as we can, both within my department and across the wider authority.
Not a danger then that more and more of the grant gets consumed by direct costs rather than delivering the service due to inflation and everything else?
Yes, I guess. Yeah, I mean, yes, there is, in as much as that's these kind of inflationary pressures and everything else that we, that we suck up. In terms of stuff within the rest of the authority, there is a bit of me, as colleagues know, which is, eventually there'll be a limit to the substitution which we can spend the grant on other parts of the authority because those preventative services don't exist. And again, that comes down to individual departments determining what they need to spend on as well. As Sam knows, I know on virtually, that's one of the things we're working on is we always have this process by which things that are allowable get passed in front of me and I have to decide whether they're in line with the grant conditions. I would want to make that process even more robust by kind of building in a written down sense of, and this is what I expect to get in terms of health improvement for the spend in other departments. So, it's not that there was any spare in the budget, but when we started making these efficiencies, I guess we managed to make efficiencies and we were able to, for want of a better word, spread the goodness as we start getting into things that you can see later on our service cuts. Then obviously that becomes more unpalatable. And I think it is more of a judgment call along the lines of which gives best benefit, what we're being asked to cut versus what we're being asked to substitute and spend it on elsewhere. And I suppose, and from that point of view, that's unresolved at the moment because that's the next stage of the process after this bit.
Okay, in which case I think we'll probably roll on to the next bit, which is the savings and savings under development, which is paragraphs 17 to 29, pages 22 to 24, and also Appendix B, which is pages 29. Back to you, Mike.
Okay, thank you again. So 17 to 29 detail quite a large number of service lines which we're proposing either through efficiencies, so essentially we are not cutting the service, but we are trimming things from the service and trying to find more efficient ways of delivering. Some are straightforward service cuts, so SR service reductions. I probably won't go through all because a number of them, 18 through to 23, are ones from previous MTFS papers that we've already put in train. So I can go over them if members wish, but I'll leave them for now because we would have covered them in previous years.
Okay, thank you very much. I think Mrs. Newton's going to ask you about paragraph 25, which is not one of those that you've just flagged.
I think I'm really concerned very much because we're talking about reductions, which to some services an actual cut. And I'm thinking of some of the services that I'm thinking of one in particular in Loughborough called the Falcon Centre. And it was classed as temporary accommodation, supported accommodation, and it received a public health budget. I think it was a contract for 30 beds. And they don't receive anything really in universal credit. So I really am worried if any funding was removed from that type of support, would that exacerbate the health inequalities relating to mental health?
Thank you, Mrs. Newton. Do you just want to switch your button off?
Oh, I am sorry. I take
no worries. So if I move on to the new ones then, and I'll pick up your question in due course. So just go through them. So the new ones we're proposing this year, Adrian, I'm checking they are the full ones we need to cover. Thank you. PH7 is an efficiency one. So health improvement, we have an in-house health improvement team, which delivers it delivers an awful lot for the budget we give away. Things like start conversations, suicide prevention work, etc., etc. So we're looking to save 130 from that. Again, we call it efficiency. Essentially, it's a sort of 17% cut in the delivery budget of that in-house team. So we'll still keep on doing things, but we'll need to prioritise, and essentially there's no getting away from we'll be doing less around some of that kind of primary prevention, health improvement work, suicide prevention, etc. Homelessness contract is coming on to your question, Mr. Newton. And Josh is here, and I might call her in to give us a bit of context on this one if I need to. So yes, we do have for some years had a contract with the Falcon Centre, who then subcontract to other organisations to deliver broader emotional support and health and wellbeing support for the homeless population. So it needs to be clear that that never has funded the core hostel provision. It's about the support services that operate out of the Falcon Centre to support the homeless. Even within the context of this year, we know we've had some nice contract negotiations because Falcon Centre said they couldn't make that pay. So I'm looking at Josh now. Is it in place now, or is it in place for next year, financial year? Yeah, it's in place already, that the two initial subcontractors have taken on the delivery. So essentially Falcon Centre aren't involved in the delivery of the service. He says, again, looking to my right, Bridge, sorry. So just going back to the Falcons and so on, do you want to come in, Josh? Because it's probably worthwhile if we can then, Chair. Is it worthwhile just saying what the relationship between the current contract and the Falcon Centre is then?
Hi everyone, I'm Joshna. I'm the AD with it, one of the ADs in public health, and homelessness that's in my portfolio. So just as Mike said, the contract that we've got is to support individuals who are homeless. So it is the emotional support, the health and wellbeing support. And for a lot of those individuals, they happen to stay at a Falcon Centre because it's a homeless hostel. So some of the staff will be predominantly sat there supporting those individuals. So it's not, when we cut that service, it's not cutting the Falcon Centre building. It's the support that the homeless individuals will receive. And that's because we're looking at integrating that provision, hopefully with our existing services through our local area coordinators, through First Contact Plus. So what we're wanting to do is provide those individuals with more holistic support rather than specific bespoke support that where it might be limited by staff that provide homelessness support. So if it's, for example, benefits, First Contact Plus will have more information on broader benefits on things like warm homes, grants, etc., etc. So it's making sure they've got the breadth of the support provided. So that's where we're going rather than the Falcon Centre itself being funded.
Would it be possible to have a briefing note on that, because it is a change in a sense to service that's actually being provided at the moment in Loughborough? So it'd be useful to have a little bit more information on where you're at, what your plans are for the future as well, because as far as those people who are involved, and they're seeing a service cut.
I think it's also fair to say that actually I think quite a few councillors have been written to by the Falcon Centre specifically over this item, so I think it might be helpful to have a universal response.
I suppose on that one, and I almost look to you on this one, there's a bit of things, well, this is our proposals for where we will save money. Of course, if that then is approved, subject to scrutiny, commission scrutiny, and then the council budget setting meeting in February, I'm a bit loath to give a kind of huge amount of detail on where before a decision's been made by Cabinet and then Council, because then clearly once that cut is approved, we'd then get into consultation. So I think we'd give a level of detail, but I wouldn't want to regard that as a sort of formal consultation or a kind of a done deal. Anyway, Mr. Morgan, you know what I mean in terms of when does the decision become a decision?
Yeah, no, absolutely right. I think it's worthwhile. I mean, if nothing else, just a simple paragraph that the council can put back, or we put back corporately on behalf of councillors, which is to actually point out the stages that we're at, and therefore, you know, where their intervention needs to come, because they are, I mean, they're contacting councils, also contacting other authorities as well, and you know, clearly from your perspective as well, if there are ongoing discussions, you need to make sure that actually they're still talking.
Okay, will do. I mean, I think at this stage, to answer your last question, will it exacerbate health inequality? Well, potentially yes, because you know, there is a mitigation which is providing a universal service, but there's no pretending that it's going to be as intense for homeless people and what we've currently got. As we're running through the service redesign, I think that there's a number of points to do with what is our responsibility from a statutory point of view versus what is that of districts. You know, and some of that kind of tale that Josh was involved in terms of working with districts around their prevention and responsibility. So, you know, there is more there than we have time for today in terms of what can we do our end, but will it exacerbate inequalities? Probably yes, because it's not the same level of service for homeless people. I'm not going to pretend it's not. Where does the blame lie? Again, it comes down to a judgment call over kind of use of the grant and then also the responsibility of districts. So we do need to explore that, and we'll do a paragraph in response at this stage, but there's obviously quite a lot in there.
Okay, are there any other further questions on those paragraphs?
Shall I do the other
Yeah,
ones
no,
before we go
absolutely.
through? So South 25, 26 is whole school approach to food again. You know, any cut is regretful for me. This has funded that program of work in schools, kind of cook and eat things, cooking classes, seeing kids grow their own vegetables. Really, the you know, the real benefit of that was about what's the best way of changing families' behaviour and generational behaviour. It is through working with children, but again, given the choice between a more secondary prevention service or a more direct service like smoking cessation and some of that kind of generation changing stuff like the whole school food approach to food, we unfortunately had chosen to go for that one. And sport and physical activity commissioning, again, I think that extends the cut seen in 22. And this is specifically around money that eventually ends up with districts via Active Together, which funds programs of work in districts, which isn't your kind of core leisure centre provision. It's sort of targeted work with groups, you know, it's Nordic walking groups, buggy walking groups, you know, it's the kind of physical activity programs for those that are least likely to exercise. So 26 and 27 from my core sense of public health worth is a real shame, but, you know, we are where we are. So that's what that would mean. It's easy to write down on a line sport and physical activity commissioning, but actually that's quite a hard hit.
Thank you. And I suspect the reality is, given budgets are just as tight probably at districts, in reality, these are services that are no longer going to be provided rather than provided by somebody else, I suspect. Okay, are there any questions from anyone else? No, on those sections, no questions. So in which case we'll roll on to the final bit, which is external influences and other funding sources, paragraphs 30 to 33, finally on pages 23 to 24.
And for this one, this is, I mean, again, this is very similar to kind of other years we've had in there. In terms of it, I mean, as we say earlier on, I mean, there are external influences. We are demand-led in a few of our services, sexual health up next, and health checks. But as I say, we do not overspend the budget, so potentially that poses an extra kind of strain on the public health grant. And inflation, again, we've covered, it's an issue for all departments. And then lastly, public health grant, because I should really have started with this first. This all assumes I know what my budget is for next year, but actually we've no idea what the public health grant is for 23, 24. So it all comes with a caveat that if there is an unwelcome and rather large cut in the public health grant, part of me would want to say all bets are off, because actually we only have the money to fund kind of core public health services and our statutory duty. So it does come with a bit of a kind of asterisk awaiting confirmation of the public health grant for 23, 24.
I think that's always the quandary, isn't it, with MDFSs, which we're expected to produce them for 3 years or more, and the reality is our funding grants are actually always the next 12 months. So the contradiction between the sort of requirements from government and what they actually do themselves is actually quite stark. Okay, are there any questions on those three items? I think they're all pretty self-explanatory, hopefully, but Councillor Newton?
It's just a note. I'm actually on page 34, and it talks about online sexual health service, which in one sense is a good idea.
So do you want to take that under the sexual health paper?
So,
you're ahead of yourself. You've got sex on the brain. You're allowed to pause for a bit. Yeah, right. Okay. Before Mrs. Newton gets off on the wrong paper again, let's finish this one. Okay, are we happy with those 3 items? I think we probably are by the sounds of it before we say anything inappropriate. Okay, right. So thank you very much. I think that concludes in that case the Scrutiny Committee's report or scrutiny of the MTFS in relation to public health. So thank you very much for that. And I think we'll now move on to the next paper. Is there something else we want to say, Mike? Sorry.
I just looking at you and really in terms of summaries, because I guess of those 4 lines, 3 kind of passed without comment, but 1 did. I'm just thinking what gets. Sorry, Chair, just in my own mind in terms of takeaways. What would we say? Probably, are we noting the comment? We'll note the comment about homelessness in terms of feeding it in, really.
Okay, thank you very much. Right, Justin's going to come and join us properly this time. Okay, so we're now on to the final paper, which is the recommissioning of sexual health services. I said we've got Joshua with us, we've got Mike, and Louise is still on the top table. So we'll take the paper as read. Otherwise, if there are any points or things that you want to flag, by all means do. This is obviously about the consultation that's currently out at the moment. So over to you, Joshua.
Thank you, Chair. So as you'll see, the purpose of the report is to seek the views of this committee on the proposed model for sexual health services to form part of the consultation. Just a sort of quick run through the service. I won't sort of reiterate everything that's in the report, but currently for us, the local authority commission services, sexual health services across Leicestershire and Rutland are divided into 2 key components. We've got the integrated sexual health service and we've got community-based services. So the current integrated sexual health service, we commission that jointly with Leicester City Council and Rutland County Council. And that contract started in 2019 and ends at the end of March of next year. And paragraph 7 describes the range of services that integrated service provides. In terms of what it looks like on the ground, we've got 2 hub locations. So we've got currently the Haymarket Health Centre in the city, we've got Loughborough Health Centre, and then we've got a range of sessional clinics that we call spoke clinics. And then we have some dedicated outreach work for very vulnerable cohorts. And then within that integrated sexual health service, we've also got an online sexual health service offer that's subcontracted, and that mainly focuses on provision of STI test kits and some treatments, oral contraception, and then our emergency hormonal contraception. And then the other element is the community-based services that are predominantly provided through our GPs and pharmacies. That focuses on long-acting reversible contraception. So that's contraception used for predominantly for birth control and is focusing on cores and implants. And then we've got emergency hormonal contraception, which is more commonly known as the morning after pill. So again, those contracts end at the end of March of next year. And so it gave us an opportunity to look at the future service, bearing in mind with the contracts all ending at the same time. Could we align them better as well? So we looked at the current need of the service, and we also did some engagement around the current model. As you'll see from paragraph 12 in the table underneath, the use of that service is mainly around STI testing and treatment. That's remained fairly consistent across the course of the contract. But what has changed is the way that the services are accessed. So when you look at the usage data, you'll see that the proportion of residents accessing clinical services has reduced quite dramatically from 64% to 39%. And conversely, we've seen a marked increase in the use of the online offer from 21% to 50%. And that channel shift hasn't been the same across all of the authorities. So Leicester City Council haven't seen that as much for their residents. But we definitely have. And we've also seen a fall in the number of our residents going outside of the LLR border to access services as well, which I think is predominantly due to the availability of our online sexual health services that's been made more accessible. So there is more information in the report around additional factors around the provision of our long-acting reversible contraception offer in GPs and our emergency hormonal contraception offer via pharmacies. I won't go into detail, But when we did do some engagement with a range of stakeholders back in summer of last year, the feedback was really helpful. And what they sort of touched upon is the importance of good access, not just in terms of the face-to-face provision, but also the digital service provision. The importance of having more community access points rather than a kind of one hub. Looking at focusing on the need to improve the awareness of the service offer. So a lot of people did tell us that they weren't quite sure what was available, what was out there. And then also the need to focus on education and awareness. And this was around tackling stigma and discrimination, people feeling like if there was a huge sign that said sexual health services, they'd be more reluctant to go in, whereas if it was a health and wellbeing hub, they were more likely to use it. So that was really helpful to kind of just have that initial feedback. So based on looking at the current provision, the challenges that we've seen with the current provision, we've put forward a proposed new model. The table under paragraph 21 sort of provides a summary of what we've got, what the challenges that we've seen, and therefore what we're proposing to change as a result. So again, I won't go into detail of that, but what we are trying to put forward is to retain at least one hub and spokes for Leicestershire, as well as having some dedicated outreach activity. What we want to do is expand the online offer so that that's available to more people, but also standardise the provision of our LARC delivery, so long-acting reversible contraception offer, and also then expand our offer that we've got within pharmacies at the moment around emergency hormonal contraception. And by doing that, the aim is to make the service more accessible, to provide local alternatives, because what we're finding is that individuals are accessing the complex sexual health services for low sort of sexual health needs, so that they're not complex, they don't need to be seen by a very sort of senior member of staff. And we're wanting to, by doing that, also then destigmatise using the sexual health services as well. What we're sort of suggesting as well in terms of the offer will hopefully provide a dedicated staffing complement. We've had lots of issues with the current service saying that they've got huge workforce issues. That is a national issue. But again, by shifting some of that into a community offer, we're hoping that will help in terms of reducing that, and then having skilled staff with the necessary skills, competencies that are required to deliver the service that we're asking, because it is very much a clinical provision. So it can't be shifted to a kind of non-clinical offering in a lot of instances. We had early discussions with Leicester City Council colleagues, and they weren't intending to make significant changes. But for us, the current model isn't going to help in terms of our residents. It's not meeting the needs of our residents going forwards. So commissioning it exactly as it is isn't really a viable option. So we did need to make some changes, and that's why we've proposed to jointly commission with Rutland County Council. We think the rurality of both authority areas, the need, the channel shift in the way people are accessing services is so similar for both authority populations that it made sense to continue with to put forward that approach. We've had approval to consult through County Council Cabinet in December, and Rutland similarly approved to commence consultation last week. The consultation launched on Monday, so at this stage can't give you much feedback on what's come forward, but that has launched successfully on Monday. So we are, and that's been promoted quite widely already. We're also intending to do some soft market testing, and that means asking potential providers a load of questions around: is the service viable? Do you think this is an appropriate model? Would you consider bidding? Anything that you're worried about, so that we can take that on board when we sort of have our final model. And that's it from me.
Okay, thank you very much. So I think there'll probably be a question coming from Councillor Mr. Newton in a second, but otherwise Mr. Charlesworth and also Dr. Hill. So Mr. Charlesworth, do you want to go first, then Dr. Hill, and then once Mr. Newton's recovered, she can ask the final question.
Thank you, Chair. Yeah, I mentioned at the briefing this morning, it's not on the homepage feed of the County Council website. I had to dig for this consultation. You mentioned it had been advertised widely. That was the first I saw of it. Whether you've done much on social media, I don't know, but I don't do much social media. And And of course, sexual health covers everybody's age. And I think if the consultation is going to be worthwhile, and it is quite a beefy consultation paper, 42 questions, I think, you know, you need to know who's accessing it, why and where. And without that information, the redesign of the service seems pretty, not poor, but you need the user's feedback to make it work. And I think you've got to get it out there more. So advertising, the consultation's good as long as you get feedback. If we have 10 responses, that's been no use whatsoever. You need people to feedback who use the service. So just promote, please.
Thank you, that's really helpful. Just for a bit of assurance, I'll take that on board and take that back to the comms team. I think also we're not relying solely on the consultation responses. We're going out to do focus groups. We've got lots of meetings that we're lined up in terms of speaking to service providers as well, and other services that deliver some form of sexual health services. So we've sort of been proactive in booking those in, and we booked all of those in last year, ready to be in.
I think it's very, very welcome to move to a more online-based service for a number of reasons. You know, if you're a young person, you're probably a bit embarrassed about this, and you may not want to go and talk to a doctor or a nurse or whoever it may be face-to-face. There may be worries about talking to someone of a different gender, and you may not feel comfortable saying, I want someone of the same sex to do this with me. And also, I mean, I'm not familiar with how many spokes there are. I know the Haymarket is the main hub. I've tried to do a bit of research, struggling to find out, you know, if I was going to book in and see someone face to face right now, where can I go? You know, I'm from Hinckley Bosworth. Well, Loughborough, but I mean, it's probably just as quick to go to Leicester, to be honest. And with the cut and the bus services that are going on, I don't know if I'll be able to get, I mean, I drive, but, you know, I don't know if residents will be able to get to Leicester, if you see what I'm trying to say. So I think it is welcome that we're moving to an online model, but I think we need to, as Mr. Charlesworth just said, you know, increase the communication that we're getting out there. My second thought is where does the limit apply? You know, talking about things like PrEP and things like that for younger residents or older residents, you know, is that a suitable thing to do online? I know you need to do regular tests, don't you? And where does education stop? Because I presume not everything will be suitable for that online delivery.
In terms of the communications, again, that it's really helpful to know, as you'll know from the report, we did get a lot of that feedback as part of engagement of not quite knowing where to go. And I think that's learning for us in terms of, I think a lot of our services were promoted through Midlands Partnership Trust's sexual health website, and actually we needed to sort of take more of a proactive approach through public health, through our channels as well. That's something we've definitely taken on board, because that's then not updated as much as we would like, and you're not quite sure. And I think over COVID, with lots of our sessional clinics closing, it's not been updated. So we'll definitely take that on board. And the second question, I think we're very much guided by clinical guidance and what the stipulations are. If there are limitations, we're not in a position to offer a service online if we're not able to. Where we can, we will do everything, but we're also constrained by the budget as well. And it's also about safeguarding. We've got to be careful that we're monitoring safeguarding ages of individuals accessing, the frequency with which they're accessing, to make sure that we've got those red flag mechanisms in place and a process for reviewing. But if it is possible, we would always want to add it to the online offer.
I mean, in the paper, when we're talking about the online offer, it talks about subcontracting to subcontracted by the existing provider. Will that still be within the same system though? So say you go online and I wanted to have some sort of service, and the response is, well, actually you need to see someone in person for that. Will you be able to easily get an appointment then in person?
That's what we're wanting from the new model. I think one of the challenges of it currently being subcontracted is that essentially it's a shift in business. I don't like using that term, but they are providing a service and wanting the income to provide that. And what we're finding is that there's a bit of friction about whether somebody should provide it face to face or whether it should be online. So I think that's something we're wanting to focus on for the new service, to make sure that there is that real joined up pathway in terms of if the advice is to go into a face to face service, that then an appointment can be booked straight away.
Sorry, Josh, is it worthwhile just kind of recapping what's level 1, 2 and 3, just so members are clear around what's online? Yeah, I know it's a test for both, isn't it? Level 1, your GP, history taking, screening, contraception. spokes, I'll let you do that. And then 3 is kind of sexually transmitted infection treatment bits, isn't it? So in terms of the spokes, as in what can't you get if you can't get online? Remind me of that one.
It's the level 2 one I'm not as sure of. The level 1 is the easy bit because it's the non-complex that can be covered through any health professional, don't have to be sort of trained around sexual health. And then level 3 is your really complex, it has to be sexual health. I think level 2 is a mixture of both. So it won't be your complex HIV cases, for example, but you can still do some STI testing and treatment at level 2, but just not to the complexity of it as it is of level 3. And that's where the spokes come in.
Well, then I was thinking about level 2. Sorry, when I was in debate between ourselves in it. So there'll be a number of community hubs which will do not the really complex, but quite complex stuff. Does the GPs that do LARC count as level 2? Because the other bit for me is worthwhile knowing is that thing about talking about comms. If your GP doesn't do LARC fitting, then actually we need to be better at then saying to people, actually, you don't need to go to your GP, you can go to a GP within the federation and do it. And I think work out that counts as level 1 or level 2. Not really matter.
Yeah, that's under level 1, and that's something that we've had a lot of feedback at the moment from residents that have struggled to access the call or implants through their own GP and not quite sure where to go. And I think that's around the staff within each of the practices not having the right information. So again, we've taken it upon ourselves to make sure that information is out there in terms of what, before the contract comes to an end, there is obviously that year with the current service in terms of promoting where you can go and what you should be saying if your health professional says, no, we don't offer it, what your alternatives are.
Sort of begs the question, that's not great from a GP perspective if they're not signposting patients to the right place just because they don't do it. And I mean, that's actually pretty awful.
I think it's the person taking the call. I think in a lot of instances. So yes, you're right. But I think it's so different. The way that the service is provided for some GPs, they provide LARC, some don't. Some provide it to only their registered patients. Some provide it to more. Some provide a specific clinic. Some just do it as part of a routine appointment, and it's so different. And that's why, again, we do want to improve that in the current service, but going forwards, that's why we want to have one provider doing the whole lot across Leicestershire to try and standardise that process.
Okay, that sounds quite positive to recognise the problem and then to try and actually design a service that solves that problem. So that's very positive. And Mrs. Newton, down to you.
I've got a cold and I'm not with it today at all. It's just a question about joining up, in a sense. I mean, we seem to be the Leicester City to me is the whole, and we're the circle around the whole. In terms of joining up, is there much work being done in terms of working with Leicester City on this? Because you would get residents from out here going in and from the city going out. Yeah, it's the joining up really.
Yeah.
The services.
Sexual health services are open access, so you can actually go anywhere, and nobody should be turning you away. So naturally speaking, they're all open to residents. So even if we progress with a Leicestershire and Rutland service, they could still go to the Haymarket. We would just lose autonomy of the Haymarket clinic in terms of if they wanted to change clinic times, we wouldn't have control over that in terms of influencing decisions, but residents would still be able to go into the city. But what we're hoping is by having a more community-based offer, there won't be a need to do that unless they want to go away from home and they choose to go out of area.
I can understand that. Thank you for that.
Okay, are there any further questions that anyone wants to ask? I don't think so in that case. Look, thank you very much for that. That's actually genuinely positive end to the meeting, actually, to see about rather than just sort of budget savings, it's also about designing a better service, which it's great to be able to do that for a change. So that's great. Thank you very much for that. Look, that draws us to conclusion. We have date of the next meeting, item 11, which is the 1st of March at 2 o'clock back in this room. And any other business, I said there's no other any other business items that have been drawn to my attention. So unless anyone quickly raises their hand and I can see them, which I can't, I'm going to move on and say that the meeting has now closed. Too late, Mr. Charlesworth.